I would like to welcome Dr. Butler. Dr. Butler is the medical oncologist at the Princess Margaret Cancer Center in Toronto and is assistant professor at the University of Toronto. Dr. Butler received his MD from Yale University and completed his training in internal medicine at Johns Hopkins Hospital and medical oncology at the Dana-Farber Cancer Institute, Brigham and Women's and Mass General Hospital. He is a medical oncology lead for melanoma and skin oncology at the Princess Margaret Cancer Center. He is also a member of the Princess Margaret Tumor Immunotherapy Program and is a clinical head of the immune monitoring team at the Princess Margaret, where his group performs a wide variety of immunologic assays to examine the impact of therapies on immune phenotype and function. Dr. Butler's research focus is on the development of novel therapies and clinical trials that include targeted therapy, immune modulation, and adoptive T-cell therapy. So welcome, Dr. Butler.
Hi, nice to be with everybody. Let me share my screen. All right, great. Okay, these are my disclosures. So today we're going to review some of the highlights from the Canadian Melanoma Conference. These conferences are medical meetings where doctors get together and review recent results, and it's really kind of the way that we communicate about new findings as soon as they're available. The main meetings that really have practice-changing presentations are the American Society for Clinical Oncology, the European Medical Society for Oncology, students, as well as people from drug companies that attend the meeting. And this is a setting that really is kind of a synthesis and review of the standard of care and immediate upcoming items that are available. It's not really the place where brand new trial data is presented. It's a much more intimate and smaller type of meeting. Presentations generally last 20 minutes to 30 minutes. There are multidisciplinary sessions where we discuss cases and people get a sense of what is the practice in Canada, what's available to us, are there any differences with what's going on around the world. We actually do have a very good attendance in terms of faculty of people that are from other countries, US, as well as Europe and Australia. So a few basics about these big meetings. I guess, and the data that's presented, some of the slides I'll show are slides from survival curves and other kind of data that's presented at meetings. I think the most important thing to understand about these curves is that they are looking at the full patient population of the patients on a trial. They're not looking at particular individuals. So whenever we talk about the average survival, that's an average number. There's only one person in the world who fits at the average number. Other people are either a little bit longer or a little bit earlier on the trajectory. So it's important to realize there's a range. The gold standard for clinical trial is survival, but we do use things called surrogate endpoints. So relapse-free survival, distant metastasis-free survival, progression-free survival, all of these are how long you're alive without melanoma causing a problem or melanoma spreading to other parts of the body. And so you'll hear people referring with these acronyms that are these surrogates, but this, in general, for understanding clinical trials, it's survival that's the main endpoint that regulators and all of us are interested in knowing. Certainly quality of life and making sure that the overall survival is good. Overall survival is important. Something called melanoma-specific survival is now being discussed, and that's because, unfortunately, we all age and die from other causes, and because our treatments are so successful, we need to look at whether or not people are dying from melanoma or other things, and that's very exciting for our field. And then there are things called that are statistical endpoints, hazard ratios, and p-values. Basically, p-value is a single number that tells you whether there's a significant difference. Hazard ratio is looking at the full length of a curve and telling you whether the different curves are different. So another bit of basic information is immunotherapy and its overall basis for immune checkpoint inhibitors. Basically, this is the concept that tumors have antigens or different elements that are recognized by the immune system. You see here little T cells that are attacking a tumor and recognizing antigens present on the tumor. Those antigens are taken up by professional antigen presenting cells like dendritic cells. Those antigens go to the lymph node, which is kind of a schoolhouse for educating the immune system. And the pupils, the T cells, learn about what's going on with the tumor, travel back to the tumor, and try to attack it. The problem with immunotherapy and one of the reasons that cancers are able to grow is that these foot soldiers that were educated to recognize the cancer, the T cells, are turned off by the tumor with immune suppressive elements. And some of the new therapies that we're using, actually now, set therapies that have been around for the last decade, these will inhibit that immune response or that suppressive immune activity, and that allows the immune response to expand and kill cancer. The types of treatments that are being used include immunotherapies like anti-CTLA-4. Ipilimumab is the anti-CTLA-4 drug we use, or Yervoy. The anti-PD-1 drugs that we're using now in the clinic for melanoma and skin cancers are nivolumab and pembrolizumab, Opdivo and Keytruda. But we're also using cemiplimab in squamous carcinoma and soon basal cell carcinoma, and other agents like avelumab and Merkel cell. And then there's a new drug that's an anti-PD-1 drug that's coming for Merkel cell. So in the first day, there was a lot of attention looking at treatment and ways to prevent relapse of early melanoma. Dr. Egermont, Patel, and Katak presented information. And Dr. Egermont's talk really was about trying to identify patients who are at highest risk, and how to monitor those patients, as well as how to modify the way surgery is done in monitoring patients. One of the items or the findings that's been quite significant in the field is that we can give immunotherapy like pembrolizumab or Keytruda to prevent relapse from melanoma. The way to understand these survival curves is that the top line is patients who receive pembrolizumab to prevent recurrence. The bottom line is if they receive just a saline infusion. And what this means is that even if you get the immunotherapy, the top line, you can still see that by 3 years, 40% of the patients have relapsed. Now, that's better than if you did not receive pembrolizumab, because 60% of the patients have relapsed at 3 years on the study. But what that means is that only a fifth of the patient actually benefit from the treatment. There are some patients who wouldn't have relapsed anyway, and some patients in the top who have recurred despite receiving the drug. And this is a curve that's important because it's looking at patients with stage 3 and more advanced melanoma. When we look at patients with stage 2, the curves overall, patients do better, and unfortunately with immunotherapy, the degree of benefit is less. So in my practice, for instance, sometimes patients end up not actually deciding to do immunotherapy. We monitor them, The one thing that was pointed out in the discussions is that so far, overall survival has not yet been proven to be different because it may be okay to just wait for relapse rather than treating early. There are efforts, however, to identify patients who have higher risk disease so that maybe we can reserve treatment for patients who are at super high risk. And as you can see in these survival curves, there's a lot of overlap. That shaded area is overlapped in some of these biomarker studies. So we still haven't found a particular biomarker that identifies the worst patients. What is exciting, however, is that there are new developments with immunotherapy in the adjuvant setting. Dr. Katak discussed the new therapy that involves using an mRNA, what they're calling neo-adjuvant individualized therapy, or individualized neoadjuvant therapy. What this involves is that patients have their tumor samples sent to the company. The tumor is sequenced, mutations are identified, and then a mRNA product is generated that's actually similar to the COVID vaccines. And then that's used to treat patients who are receiving adjuvant therapy. And in an early phase 2 study, there was a significant difference between patients who received pembrolizumab with the individualized neoadjuvant therapy versus pembrolizumab alone. And this was without additional toxicity. So there are other combination therapies that have been investigated in recent years. And unfortunately, while there may be some increased toxicity, side effects, there's not a difference in survival, or in this case, it's called relapse-free survival. So that means the patients on the bottom curve have a higher percentage of patients relapsing compared to the top curve where patients are not relapsing. Now, most of patients with melanoma have their diagnosis in the family doctor or dermatologist's office, and if we're really good at monitoring patients, we'll find patients early. And after that initial assessment, there's really no further tumor left over for left over at the time of surgery and completion surgery to prevent relapse. Vaccines and immunotherapy works at preventing relapse, but what's actually found is that the few people who actually present with larger tumors that are still present at the time they see the oncologists, it turns out that if we start treatment before the surgery, we can induce better response. And probably what's involved is, you can see here in this figure, there's a tumor that's being resected. The patient receives the antibody immunotherapy treatment, and you induce an immune response. Those colored cells are activated T cells that are fighting and killing off tumor. On the bottom figure, you give the immunotherapy first, and then you do the surgery. But because the tumor is present at the time of the immunotherapy is given for a few cycles, we actually induce a much stronger anti-tumor response, and this potentially will result in better outcomes for patients. What was found in the last few years is that that's indeed the case. You can see here, SWOG 1801 was a clinical trial where patients received immunotherapy prior to surgery, the neoadjuvant arm, and a lot more patients had no relapse compared to the patients who received treatment only after surgery. There's a figure on the right where patients received a different doublet therapy called nivolumab, relatlimab, that's Opdualag, and the results are really promising in that small, just only 29 patients, but promising clinical trial. And then over the last year, there's been data that was presented at ASCO using the combination of ipilimumab and nivolumab, and you can see this big difference in outcomes between patients that received just 2 doses of combination ipilimumab and nivolumab compared to nivolumab alone, which is the red curve. What's really interesting is some earlier data that looked at the pathologic response. And as I was mentioning, we haven't really figured out the best biomarker for monitoring patients and to choose who should get adjuvant therapy and who shouldn't. But with the data for this neoadjuvant approach, where you give the immunotherapy prior to resection of disease, if those patients have a major pathologic response, patients basically don't relapse. You see all these curves at the top where patients do very well. Patients, unfortunately, who have partial responses or no response do a little bit worse, and therefore we're looking at trying to improve the outcomes for these patients as we try to identify new approaches. Now, we also, on the first day, discussed cell therapies. There's a treatment called TIL therapy, which has been studied for several years, actually back into the 80s and 90s, where cytokines, chemicals that help to promote immune responses in the laboratory, are then used as a treatment for patients who have cancer. And we've been dealing with these treatments as a therapy. In what TIL therapy involves is a procedure where patients have a surgical resection of a tumor. The lab processes that tumor, and tumor-infiltrating lymphocytes are expanded to large numbers. And then the T cells are infused as a treatment after patients are given lymphodepletion to make room for the T cells. Patients then received IL-2 administration and then are finally discharged. This is a very involved process. It can take a month or so to generate the T cell product. The chemotherapy and the IL-2 are pretty toxic. So what you see in this figure is the high amount of toxicity that's experienced by patients in the first couple of weeks. But then afterwards, this one-time treatment is done, and patients do not have further toxicity. TIL therapy by the company Iovance was studied in this clinical trial, and in patients who have received anti-PD-1 therapy. Most of the patients had been exposed to CTLA-4 therapy, ipilimumab, and yet they had a very good response to therapy, a large number of these patients. This is what you call a waterfall plot, where you look at changes of the tumor size. If the figure goes down, that means that the tumor is shrinking. If the bar goes up, that means the tumor grew for that patient. So in this study with a drug called lifileucel, the patients who were treated, many of the patients had durable responses that lasted a long period. And this has resulted in an approval of lifileucel, or it's now called Amtagvi, and it's been approved for treatment of patients by the FDA. It's currently being reviewed in Canada, and we'll see how the health technology assessment progresses over the coming years. There is also a new treatment called OBX115 by a company called a company called Obsidian. This is where the TIL product is obtained from a surgery, and then the TILs themselves are engineered to express a, a protein which allows the TILs to expand and grow when a second pill is administered. If you give the pill, patients will have the TIL expand. If you stop taking the pill, the the TIL then disappear. And in that early study, about 20% of the patients in a very small group of patients had responses. This has resulted in treatment of patients in a phase 2. They've identified the recommended phase 2 dose and a clinical trial looking at patients that will either receive this treatment or alternative treatments will probably be initiated in the next year and a half. And we're hoping to have this study at Princess Margaret and other sites in Canada. Dr. Wong, who is originally Canadian, trained in Canada, but it was up until recently was at MD Anderson and now is at Roswell Park, discussed oncolytic virus therapy. This is an approach which is really promising for patients where immunotherapy hasn't been effective and involves injecting a virus directly into a tumor mass. The virus is engineered so that it grows only in tumor and that it also activates the immune system so that you can have both attack of the tumor that where the virus was injected, as well as activation of the immune system so the immune cells can then travel to the tumor at distant sites. Here's an example of a patient who had a progression of a tumor on the scalp as well as the liver. Post pembrolizumab, some of the tumors were injected with the oncolytic virus, and responses were observed, and also other areas that you can see in these yellow areas, tumor shrunk with treatment. Apparently, this type of approach is most effective when at least half of the tumors are available for injection with the virus. But what you can see here in this waterfall plot is that both injected and non-injected tumors will shrink. The injected ones are the blue ones, and the red ones are non-injected lesions in this series of patients. So there are some promising results here. There's a randomized study looking at this treatment versus standard of care that is opening soon. And we're also, again, hoping that we can get this study open and going in Canada post immunotherapy in patients who unfortunately have growth of their cancer. The session also concluded with a legacy award given to Dr. Cheryl Rosen. Dr. Rosen is a dermatologist at UHN, and she has been pivotal in terms of sun safety education. She was very important in getting the Ontario legislation approved so that children are not allowed to use tanning beds, or at least have to be. I think they are barred, or now I can't remember offhand. But she was very important in getting that legislation because, as you know, tanning, artificial tanning, is not a healthy practice. Then the next day we discussed Merkel cell carcinoma with Dr. Bhatia, who's from University of Washington. Merkel cell is a rare type of skin cancer. It tends to be seen in older patients. It is a lesion that tends to grow fast and can be quite aggressive. It's caused by a virus or UV sun damage. In Australia, most patients have UV-related Merkel, whereas in North America, most of our patients have Merkel cell that's related to the Merkel polyoma virus. There are many options for these patients, chemotherapy as well as immunotherapy. Avelumab is currently funded in most Canadian provinces. Nivolumab and pembrolizumab have been shown to be effective in smaller clinical trials, but there's also a study that's resulted in first-line Health Canada approval of a drug called retifanlimab. Avelumab's only available for the most of our patients after chemotherapy has been attempted. Retifanlimab is a first-line indication, so hopefully after the health technology assessment, we'll be able to have access to Reti, which I think is a better option for patients. Now, one of the challenges is that compared to melanoma, where you treat for 2 years in many patients or 1 year in many patients and you stop the drug and they never relapse. Merkel cell has a much higher relapse rate. About half of patients will relapse when you stop drug. And Dr. Bhatia presented their experience where they are continuing patients on immunotherapy, but after 2 years, but not as often. So they'll receive treatments in the every few months rather than every 2 weeks, as is standard practice. There is a clinical trial that's headed by Dr. Neem, who's at University of Washington. Ontario is participating in this study with a drug that's involved in cell cycle checkpoint, an ATR inhibitor that's given to patients. So hopefully this will result in good results for patients who are unfortunate and have progression despite immunotherapy. There was also a review and discussion of special populations. Cutaneous squamous cell carcinoma, clinical findings of presentation and management was presented by Dr. Claveau, who's from Quebec City. Also, neoadjuvant for squamous cell carcinoma, cutaneous squamous cell carcinoma was presented by Dr. Gross. He's a head and neck surgeon from MD Anderson and has been a great proponent of using this approach for squamous cell carcinoma. Dr. Migden also discussed advanced basal cell and new treatments that are being developed. Dr. Silk from MD Anderson presented strategies for treating patients with immunotherapy in the solid organ transplant setting. As you can imagine, if you release the immune response and a patient has a solid organ transplant, there's a high risk of the immune system not only attacking the patient's tumor, but also attacking the organ. And there has been a fair amount of research in different immune suppressive drugs. It appears that drugs that inhibit the mTOR pathway can be used. They prevent rejection, but they also will allow an anti-tumor immune response to occur. And then Dr. Silk discussed how you can switch patients' immune response treatment, immune inhibition treatment to a more favorable approach, and then give immunotherapy. And there are many successes where patients do not reject their transplanted organ, but are able to have responses against the cancer. Obviously, there's a lot of work in this area that's needed. But there are promising results. Dr. Hochschild, a dermatologist from Germany, presented data about local therapies for melanoma. He and others have studied a drug called Daramune, which is a drug which is able to activate the immune system using cytokines that are effective at helping to boost an immune response. And he reviewed this data. There is a clinical trial that's likely to move forward in the coming months, and they've approached Canadian investigators to participate. So hopefully this approach will be ongoing. Dr. Robert from Paris presented an excellent review of the up-and-coming new therapies, including vaccines, the oncolytic virus approach, as well as new immune checkpoint inhibitors and cell therapies. She also took a little time to discuss her lab research work, which was quite interesting. The concept that she's been working on for the last few years is the concept of persistent cancer cells. As you can imagine, we'll have some patients who receive treatment. I think targeted therapy is a great example where their cancer completely disappears when you receive the targeted therapy. And you can see that with this waterfall plot that you see at the bottom here, where there are patients that have complete responses and all the cancer is gone as far as what you can see on scans. And even where you use more sensitive assays like circulating tumor DNA. And what she has been studying in the lab is using targeted therapies and other approaches to try to induce an excellent response in vitro, but then studying the biology of the cells that are not completely killed off. This is what she calls persistent cancer cells. And then understanding the changes that occur in the persistent cells that allow these cells to survive the anti-cancer therapy. Her work is then trying to understand these mechanisms so that she can understand the role of relapse. Because it's not, when patients have relapse, it's not that a cancer reappears out of nowhere. It's coming back from the persistent cells that are not completely eliminated by the therapy that we have. And then on the third day, Dr. Joshua presented some recent developments in the uveal melanoma space. Uveal melanoma is a cancer of the eye, which comes by multiple names. Ocular just means eye. Uveal melanoma is a term that's referred because the melanocytes, the pigmented cells, are derived from the uveal tract in the eye. And then you'll also hear a term choroidal melanoma, because choroid is this part of the eye that has these melanocytes. The eye, usually the pigmented cells help in vision, but it's possible that these cells can develop changes that allow the tumor to become to grow. Uveal melanoma, as you can see, is derived from initially precursor lesions, so what are sometimes called freckles or nevi, that an ophthalmologist or optometrist can see when they do an eye exam. This occurs because of a derangement in a G protein. And then additional mistakes are made in these cells, and those mistakes allow the tumor or the cells to grow and to form a tumor, as well as allows the cells to develop the capacity to spread to other parts of the body. Uveal melanoma is unique in that it's a type of melanoma that's quite rare, only 3 to 6 per million per year. But compared to skin melanoma, it's much less mutated. There are only a handful of mutations. There are a lot of chromosomal abnormalities, but it's not a highly mutated disease the way skin melanoma is. It also has a high expression of an antigen called GP100, the target of Kimmtrak. This is a figure that just shows the uveal melanoma uh, uh, arising from either the choroid, the ciliary body, or the iris, and shows that the most common initiating mutations are GNAQ and GNA11 mutations. There are also other less common mutations that are involved in initiating of this type of cancer. Um, and then the second hit that occurs will impact the ability of the tumor to grow faster. BAP1 is a second hit, which is associated with a more aggressive behavior. SF3B1 is a little less aggressive. Tumors can still relapse, but they tend to relapse late and spread late. And then the tumor can be a little less aggressive in its rate of growth. EIF1AX allows tumors to grow locally, and while these tumors can still spread to other parts of the body, it's a little less frequent. As I mentioned, the G proteins, which you can see on near the cell surface at the center top of this diagram, these proteins are deranged in uveal melanoma, and there are different studies that are being used to try to target this. Darovasertib inhibits a protein called protein kinase C, and this turns out to be effective in controlling the cell growth. And when drugs are given as to inhibit protein kinase C in combination with second drugs to induce a response. There's a in vitro data, laboratory data that shows if you combine darovasertib, which inhibits the protein kinase C protein, along with a drug that hits or inhibits function of MET, that you can induce a response. And a drug combination called darovasertib and crizotinib is currently being investigated. Dr. Joshua discussed the early data in the phase 2 and phase 1 where patients received darovasertib plus crizotinib, and a very high percentage of patients had shrinkage of tumor. In the sort of 30 to 40% range, and a lot of stable disease, at least initially. When circulating tumor DNA is analyzed, it looks like we have a really good control rate of tumor. There is resistance that develops in these patients, but certainly there's effective therapy initially, and that's really a big difference from what we see with other approaches for uveal melanoma. There is a randomized phase 2, phase 3 study that's ongoing where patients are randomized to the combination of darovasertib and crizotinib versus standard treatment. This study has completed the phase 2. They identified the proper dose. They compared 2 different doses of darovasertib, and the phase 3 is ongoing, and maybe full accrual will be met by in the next 6 months to a year. Then we'll be waiting for results, and hopefully we'll see results that will result in regulatory approval. I would anticipate that if we achieve regulatory approval, that there will be a compassionate program as the drug is analyzed by the health technology assessment team going forward. What is also kind of exciting that Dr. Joshua has been involved in is, again, giving darovasertib to patients who have advanced ocular disease. at presentation, so not when the disease has spread to other organs. And in his study, where he looked at patients with eye tumors, he gave the darovasertib in patients who were going to have their eyes removed as a treatment. He found that a high response rate or shrinkage rate, that's what you see with the waterfall plot on the right. The thing on the left is percent change over time, where you see the numbers going down, mean that the tumors are shrinking. And he was able to prevent the need for enucleation or removal of the eye in these patients in 75% of the patients. So the drug has been effective and is being studied in a clinical trial that we have open. It's basically on pause right now in terms of accrual. There will be some slots for patients who are scheduled for plaque treatment, where we give the drug to try to shrink the cancer a little bit more. And then the study will wrap up, and this summer there'll be a randomized study to look at patients, either standard of care or moving forward with this darovasertib drug to try to shrink the cancer. There was also discussion regarding targeted therapy. This is a figure that shows the effect of giving targeted therapy, dabrafenib and trametinib versus ipilimumab. What you can see in these survival curves is that initially the targeted therapy is quite effective at preventing early death, and much better at controlling disease in the short term compared to combination immunotherapy. So typically in patients who have high bulk disease, who are really sick from their melanoma, will choose targeted therapy in these patients early. But if you switch the patients, it does, however, it is a problem if you continue the targeted therapy and allow resistance to develop, because the immunotherapy is actually more effective at controlling tumor long term. And with the recent follow-up data, this has been confirmed that patients do better on immunotherapy long term. So if a patient has limited amount of disease, we'll actually choose immunotherapy for them as opposed to targeted therapy. Now, unfortunately, not everybody responds to immunotherapy and then will receive targeted therapy. Targeted therapy, unfortunately, does develop a resistance. Also, targeted therapy is not effective for all BRAF mutations. The drugs, encorafenib, dabrafenib, and murafenib, all of which are available in Canada, will help patients with class 1 BRAF mutations, but will not be helpful in patients with other types of BRAF mutations. There are promising inhibitors of BRAF. There's a new dimer inhibitor that's currently being studied and is in clinical trials at sites across Canada. That's a drug that's made by Pfizer. It also is very effective at getting inside of the brain, as the pharmacology is developed so that it's brain penetrant. And this agent is not only able to inhibit the regular class 1 BRAF mutations, but also inhibits class 2 and class 3 mutations, as well as which are present in patients with these alternative mutations, as well as a mechanism of resistance. So for patients with the classical BRAF mutations. So these agents are currently in clinical trials, in expanded trials. You can see here waterfall plots in the early clinical trial in the phase 1 study, where optimized dosing was identified for this BRAF inhibitor. And then finally, at the end of the sessions, we had a session where toxicity management was discussed. Dr. Ryan Sullivan, who's at the Mass General, discussed their clinical program where they study patients with immunotherapy-related toxicities. He discussed the data that supports proper use of immune suppression in these patients, where because there are some downsides to prednisone and other immune suppressive medications. And he reviewed that data. Dr. Max Sauter, dermatologist who has an interest in cutaneous toxicities, reviewed extensively the multiple types of skin toxicities that occur with immunotherapy and the management of them. Dr. Saltman, who's a rheumatologist and an expert on immune checkpoint inhibitor toxicities, reviewed her approach with managing arthritis as well as other less common skin and other immune-related toxicities. And then Dr. Davis reviewed the cardio-oncology. One of the rare toxicities, but devastating toxicities, is where the immunotherapy allows the immune system to affect the heart and other muscles. And she discussed her approach at managing these toxicities and preventing long-term illness in patients. So in summary, there are many successes, and these were highlighted throughout the Canadian Melanoma Conference. Many patients are helped with these new therapies, even patients with high risk for relapse, as well as patients with advanced disease. I think the big story for the last year and a half or so is neoadjuvant therapy. There is a new combination therapy that's being funded by most provinces. This is a combination of nivolumab and relatlimab or Opdualag. This is an alternative to treatment with combination ipilimumab and nivolumab. It has similar response rates but less toxicity. Merkel cell carcinoma is back in the news with a new first-line therapy. Hopefully, we'll get funding of this agent soon. There is a lot of hope for the future. Cell therapy with TIL therapy and other approaches are being investigated, as well as hopeful approval in the coming months. There are new therapies for uveal melanoma with the darovasertib, crizotinib. People are continuing on Kimmtrak, which is an effective therapy, and we know that Kimmtrak is the results in overall survival benefit. Oncolytic virus therapy, I think, is going to be a major focus that we really, as a healthcare system, need to figure out how to deliver in a timely fashion to patients and make sure that all of these options are available, as well as new targeted therapies are being developed for uveal melanoma as well as for BRAF mutated melanoma. There are some additional studies for NRAS that will hopefully be opening in the next few months as well. So with that, I'd be happy to take questions.
Butler, for your wonderful presentation. We have had a number of questions come through. Okay, so first question, excuse me, that we had come through is in regards to the trial ID-196. Do you know how long this is going to run and what happens to patients once the trial has ended?
Well, the trial is so currently the first line study is for HLA-A2 negative patients. So if they're not eligible for starting Kimmtrak, they can go on to the clinical trial. Word on the street is that the study will be open for probably up until the end of this year. It is accruing quickly, and then it'll be closed. The question about what will happen next is that uh, the companies are not required to make the drug available. Uh, they do have limited drug supply, but most likely, I mean, this is based on prior experience. If they get FDA approval, then they'll have a compassionate program. Uh, there will be a way to access the drug through a special access program at Princess Margaret and other centers around Canada. There was a brief period of time where the drug was available through a compassionate program. We were able to obtain it, so there should be a pretty low barrier to getting access. But it really requires that the primary endpoints of the study are met so that um, and that they're very close to FDA approval or have received FDA approval. Usually, I don't, there is something called Project Optimus where the drug can, not Project Optimus, sorry, Project Optimus is about drug dosing, and I'm blanking on there is another FDA related project where Orbis, where they can get early approval in uh, Europe, I think UK, uh, maybe not Europe, it's UK, Canada, Australia, Israel, some other centers. I'm not sure whether they're using Orbis for darovasertib or not. Apparently, there's various issues. But obviously, we want to try to advocate to get the drug available in Canada, and then we'll be able to use it um, and uh, going forward. So we're very optimistic, but it's probably going to be, I mean, the optimists will say that it'll be 2026, that and the earlier that, or maybe at the end of 2025, it'll be available, but it's that's a big ask.
Yes. Okay, thanks so much. And a question also relating to the same trial, the ID 196. From the data so far, does it look more promising than Kimtrack?
Well, I think the biggest question, so we don't know, and it's not being compared head to head to Kimtrack. It's only being looked at but currently in patients that have either basically the randomized study is comparing immunotherapy to IDE 196. And then regarding Kimtrack, we have really good data about survival. We don't have that kind of data yet for IDE 196 or darovasertib, so we'll see. Certainly, the percentage of patients that have shrinkage of the tumor is higher with darovasertib. The big question is durability. Just because you have a tumor shrink doesn't necessarily mean that patients live longer. It really has to do with how long that disease control occurs, is the critical question. I think we'll have to wait and see what we're seeing in the HLA-A2 negative patients, and then we'll be able to develop some understanding about its role in patients who are A2 positive. One of the findings or one of the experiences that we have from skin melanoma is that targeted therapy, while it has a higher response rate, does not result in better long-term control. So it's better to do immunotherapy even though there's a lower response rate. Lung cancer is the opposite. It's better to go on targeted therapy if you have an option because you have a mutated gene in lung cancer. So for uveal melanoma, we'll probably have to do a randomized study to answer that question. But hopefully we'll learn something from the current studies.
So much. Um, and we have a question come in regarding the mRNA.
Yeah.
Um, could you comment on when this would be expected? in clinical setting?
Yeah, so that's a very interesting question. So the randomized phase 2 reported out within a couple of years. The study finished the treatments. It's fully enrolled. I think there are some patients that are still in their first year. It's going to be at least 2 or 3 years before we see a separation of the curves. It was a standard patient population, and one of the problems, of course, is if you include a lot of patients with stage 2, because those patients do better, they don't relapse right away, so you don't see the big difference. But the study was designed to look at all of the patient populations. So it'll probably be 2 or 3 years. It is, however, as you can imagine, a major, major, major focus for the drug company Merck. Pembrolizumab is coming off patent, and they're really hoping that the individualized neoadjuvant therapy vaccine is going to be helpful in treating patients. So we'll see. So I don't think there'll be any delays in getting the results out, but it looks like it's going to be a few more years. Now, the other thing to remember is that that's a drug that's important at preventing relapse. It's not a drug that's been proven to be effective in this stage for metastatic setting. There are trials that are being developed in that area, but that has to be proven that it can help patients who have already had their disease come back.
Okay, thank you so much. Um, and we have another attendee who's seeking clarification regarding the Darrow-Vister, whether this can be used for patients in the beginning when they don't have mets yet.
So, very good question. So, darovasertib will be studied in patients who haven't had their eye treatment yet. There's a randomized study, phase 3 randomized study, late phase study that'll be starting this summer. There are centers in Alberta, probably Vancouver, Montreal, Ontario will be doing that study. Um, the a really good question is whether this is a drug that can be given after your eye treatment to prevent later relapse. And the company, as I mentioned, or kind of indicated, they have a drug supply issue, so they're not designing the what we call adjuvant study yet. It's not going to be running this summer, for instance, but they are working on trials, and it's likely we'll have an adjuvant study in the next year or so. Um, the and there'll probably be a cooperative group study, although that's kind of up in the air. But we are hopeful that this drug will be used to prevent patients from developing METs. There is also a study that has been designed. It's been open in Europe, but it's not yet open in North America, looking at Kimtrac or tebentafusp to prevent development of METs. It's a bit of an ask because you don't have cancer and you're going to receive a treatment. In this case, only 6 months, but once a week for 6 months. So whether that's everybody's cup of tea, we're not sure. But that study has started, and we're working on trying to get that open in North America. It's led by group in the US, and we're participating in that. There's some delays in getting things through the regulatory agency, but hopefully that'll happen soon.
Thank you so much. Um, and we have another question regarding uveal melanoma. So this is coming from a cutaneous melanoma patient that had eye adverse event while on immunotherapy. From what you have seen, are people who have had eye adverse events at an increased rate to develop ocular melanoma as compared to those who never had any eye-related
No,
adverse
I don't think
events.
so. Yeah, the like uveitis or other side effects that are caused by uveal melanoma don't induce additional cancers in the eye. So I think the patient's going to be okay.
Yeah, and this clarity as well for uveal melanoma, does UV exposure cause
Yeah, that's a
UV?
great question. There's not a there's not an ultraviolet signature in patients with uveal melanoma seen in the tumor, so we don't think that UV induces these tumors. UV signature is where there are genetic changes, and you can actually look at the genetic sequence of the mutations, and certain sequences are favored by ultraviolet light as opposed to other types of mutations. So we don't think it's associated, or UV exposure is associated with uveal melanoma. That being said, it's interesting. Fair-eyed, blue-eyed people are at higher risk of uveal melanoma compared to patients with brown eyes, and it's more common in Northern European than Southern European or other non-white populations. So um, it's there's some interesting correlations, but it's not UV that's causing the this type of cancer.
Thank you so much. So I think we have enough time for one more question. Um, and this question is, a large number of cancers have benefited from immunotherapies originally tested with melanoma, yet melanoma doesn't seem to have benefited from other types of therapies for other cancers. Do you have any thoughts as to why?
So the what you're basically referring to is that chemotherapy doesn't work very well for uveal melanoma. Sorry, for melanoma in general, and that is been noted for many years, and there are other types of cancers that don't respond to chemotherapy. Melanoma is also quite resistant to radiation. There are other tumors that have that characteristic. It's not, I think it's just the biology of the melanoma is such that those types of approaches don't work. Uveal, sorry, not uveal, but skin melanoma, BRAF mutated, is the poster child of targeted therapy. It, was quite remarkable in terms of responses observed. The biggest challenge is the development of resistance. This may have a relationship to uh, skin melanoma where it's highly mutated, so it can develop resistance quickly. Some of lung cancer is a good example of targeted therapy where patients can be maintained on these therapies for a long period of time. The mechanisms of the development of resistance are different. So in in lung cancer, there are changes in the relationship between the way the drug targets the tumor, and then new drugs can be developed that target those mutation changes that occur in lung cancer. That's being attempted in melanoma, but it's been a little bit harder, mainly because the mechanisms of resistance are a little bit different. It's like in terms of melanoma, because of the mutations, this is my personal theory, that because of the way the mutations occur, there are more opportunities to kind of get around, just completely bypass the way the drug is inhibiting the cancer, whereas in lung cancer, it's changing the way the drug and the tumor interacting that the lung cancer is able to grow, and then it's easier to make changes in the drug in order to target those tumors.
Thank you so much. And we may take this is one last question. Um, Interested to hear from you. What was your biggest highlight or takeaway from this year's melanoma conference?
I think that the biggest takeaway from the conference is the advancements that we've made in these neoadjuvant approaches, and the way that the best or the knowledge that the best way to treat patients is by collaborations across disciplines, where the dermatologists, the medical oncologists, the radiation doctors, the surgeons are all working together to treat the patients so we can use our different skills to come up with the best treatment plan for patients to help them. And that has come to fruition with the neoadjuvant approaches. Canada is quite unique, actually. You guys, we should all be very proud that we have a way to do a formal review of off-label use of these drugs through Canada's drug agency, and that's going to accelerate adoption of these treatments as opposed to other jurisdictions where people have to develop treatments that are off-label without really any clear direction from a data review. And it just allows us to come up with a more coherent and rational use of new drugs, and that's happening in the neoadjuvant space.
Okay, thank you so much. I appreciate you taking the time to answer all these questions. Thank you all for attending this evening's webinar.